Morning, everybody. I'd like to thank the committee for the privilege of this podium. My name is Joshua Landreneau. I'm a general surgery resident at the Cleveland Clinic, and today we'll be talking about our enhanced recovery pathway following peroral pyloromyotomy, or POP, comparison of safety and cost. We have no relevant disclosures, but outside the scope of this presentation, complete disclosure here listed. Gastroparesis is a devastating functional disorder of the stomach with chronic symptoms of nausea, vomiting, early stadium bloating, characterized by delayed gastric emptying without mechanical obstruction, and whose etiology has classically been defined as diabetes, post-surgical, or idiopathic. The incidence of gastroparesis has increased significantly over the past several decades, likely due to the diabetes epidemic, with a study done by using the national inpatient sample showing that admissions with a primary diagnosis of gastroparesis increased over 300% from 1997 to 13, with total aggregate charges, or the national bill for treating gastroparesis, increasing over 1,000% in the same time period. The initial treatment of gastroparesis relies on diet and lifestyle modifications, as well as pro-motility antiemetic agents, but unfortunately these tend to lose their efficacy over time and are associated with intolerable side effects. So several surgical and endoscopic treatments do exist with varying efficacy. Today, we're going to focus on more pyloric-directed therapies. So we first started performing peroral pyloromyotomy at our institution in December 2016. This technique involves the development of a submucosal plane to access the gastric pylorus, where it's then divided, analogous to a surgical Heineken-Michelitz pyloroplasty. The scope is then withdrawn and closed with endoscopic clips. So POP, their early experience is this very promising therapy, with our first 100 cases showing significant improvement in symptoms and objective measures of gastric emptying. And our initial experience and others published showed that POP generally has a very low perioperative morbidity. Our original pathway involved doing each procedure under general anesthesia in the operating room with subsequent inpatient admission. The patients were kept NPO overnight and evaluated with a post-operative 1 upper GI series, and then started on a clear liquid diet. Our first 100 series reported a mean length of stay of about 1.5 days. And this length of stay was actually lower than most other published accounts, where other centers reported mean length of stays of up to 5 days. However, we did aim to improve on our already low length of stay with development of some enhanced recovery pathways, with the goal of making POP a safe outpatient procedure. And some of these changes that have evolved as we gain more experience with POP have been: we now perform it routinely in the endoscopy suite. We no longer use antimicrobial prophylaxis in each patient. They're discharged after monitoring for emergence from anesthesia. They can clear liquids on the day of the procedure, and we no longer obtain routine imaging. So to date, there have been no studies looking at outpatient POP, and we aim to compare the outcomes as well as looking at our perioperative management. We did this with a propensity match series based on age, gender, etiology of gastroparesis, as well as American Society of Anesthesiologists' physical status classification to help control for any selection bias, that we would only offer outpatient POP to the most healthy patients. We had 54 patients undergoing POP with inpatient recovery, matched with another 54 with same-day discharge. So our mean age was around 45 years. Unsurprisingly, it was female predominant based on the epidemiology of the disease. The most common etiology of gastroparesis was idiopathic, followed by diabetes and post-surgical, and again, there was no difference after propensity matching. Most patients were ASA physical class 3, which reflects the high degree of medical comorbidities in this population, with no differences in the two cohorts. So those having outpatient POP were much more likely to have been performed in the endoscopy suite versus the operating room, which was nearly universal for the inpatients. The operative time was less in our outpatient cohort. In each case, there were no procedural complications, and we had technical success in each case. So outpatient POP had no increased risk of complications within 30 days. There was one case of gastrointestinal hemorrhage requiring transfusion in both cohorts. This was due to non-adherence to post-op PPI and sucralfate regimen. One patient had a negative diagnostic laparoscopy for abdominal pain. There was also no increase in readmission with outpatient POP. In fact, a trend towards a decrease in the readmission rate. So as far as looking at our variations in care pathways, only a minority of patients with the outpatient were studied with a post-op upper GI. In each case in both cohort, there was no leak of contrast medium or obstruction. Interestingly, capnoperitoneum was a very common finding in up to 40% of patients, but this did not place patients at increased risk. As far as antibiotics as well, we no longer offer it routine. In our outpatient cohort, 50% had no antimicrobial prophylaxis. And importantly, there were no infectious complications. As far as cost data, here demonstrated is the total cost of the institution. This is not billed data, which is variable based on insurance provider. Our IRB does not allow for reporting for actual dollar figures, so these are ratios of the cost, comparing the two. And unsurprisingly, the outpatient POP for the procedure and recovery itself was much less. But we would expect these costings to evaporate if there were more complications or readmissions. This did not happen, and it was significantly less at 26% with outpatient POP in the whole perioperative period. So in summary, we found that there were no increases of complications or readmission with outpatient POP. There was no increased risk of infectious complications with no antimicrobial prophylaxis. And in post-op upper GI, there's frequent capnoperitoneum, but this was not associated with complications. And we concluded that outpatient POP has no increased risk of readmission complications, costs significantly less, and imaging is not necessarily required. If so, capnoperitoneum is common, but does not increase risk of complications. And finally, outpatient POP is safe and feasible. Thank you very much.